Welcome, everyone, to Sustain ED, Substance Use Screening and Treatment Approach in the Emergency Department. This is a lecture called Bup 101, or Buprenorphine Basics. My name is Jean Marie Perrone, and I work at the Hospital of the University of Pennsylvania, and we have an ED buprenorphine program. This was funded by SAMHSA, and I wanted to acknowledge the work of the Bup 101 group, Dr. Kat Lee and Dr. Utsa Khatri, as well as the staff at the American College of Medical Toxicology. I have nothing to disclose. Today we're going to learn a lot about buprenorphine, the pharmacology of buprenorphine, methadone, and naloxone, and identifying common barriers to prescribing buprenorphine, as well as the clinicians who can order buprenorphine. So we all know the opioid crisis continues to escalate. Currently, 47,000 people have died of drug overdoses in the last year. A large proportion of them now from synthetic opioids, including fentanyl, carfentanil, and designer opioids, a small subset dying from heroin, and still some number of people dying from prescription drug overdoses. We know that these patients are in the emergency department. Patients with opioid use disorder present to the ED seeking treatment for their medical problems and complications of opioid use disorder, as well as seeking treatment for opioid use disorder itself. We also know that we take care of patients who have just recently overdosed from a prescription opioid or synthetic opioid. When we're taking care of patients in the emergency department, it's especially important to remember that patients who post-overdose have some of the highest mortality of any patients that we take care of in the emergency department. This study, initially published in abstract form by colleagues at Mass General, included initial findings that 10% of the people who received naloxone or Narcan in the field in Massachusetts died within 1 year. That 10% mortality is incredibly high compared to any other illness that we care for, stroke, heart attack. Nothing comes close to 10% mortality at 1 year. In a further analysis of this data set, colleagues at Mass General looked at a cohort of approximately 11,500 patients who had received naloxone in the field and found that 6% of them actually died within 1 year, and further realized that 1% of them died within 1 month. And that's 20% of the patients who died in 1 year died in 1 month after the overdose. And looking at this graphically, in the 30 days post-overdose, 130 patients in that cohort died. So these are the kinds of things that we can really intervene on in the emergency department, because patients who are walking out who have mortality in the range of at that one period in the next 30 days is incredibly high and really concerning. The reason that post-opioid overdose period is such high mortality is initially when patients are using opioids, there is quite a bit of euphoria, and they really go from feeling normal to experiencing euphoria. They're always trying to get back to that sensation of euphoria, but as tolerance and dependence occur, it becomes much less easy to achieve euphoria, and so they're always escalating the dose. Really, in the later stages of chronic use, they're really going between normal and using opioids just to not feel opioid withdrawal, and they never really get to that euphoria state. When patients then we see in the ED with an overdose, they're really at that junction of trying to get to euphoria, but really not able to achieve it, and pushing the dose and often overdose at that time and then subsequently in the next 30 days. We have a lot of public health data to say that when we expand the use of methadone and buprenorphine, we protect patients from the risk of fatal overdose. This is data published about expansion of methadone and buprenorphine in Baltimore. There was a heroin epidemic there in the 90s, and the dashed lines represent expansion of methadone slots in methadone clinics, as well as increasing access to buprenorphine from office-based therapy in the dotted green line. As buprenorphine access increased, the red line represents deaths declining. So we know that on a public health basis, the more buprenorphine we can prescribe, the more we can impact overall death rate. We have excellent evidence that this ED can be the site for initiation of buprenorphine. Gail D'Onofrio and her colleagues at Yale published a series of 350 patients who were started on buprenorphine in the emergency department. What they found at 30 days in the far right bar was that patients who were started on buprenorphine and received their first dose of buprenorphine in the emergency department were twice as likely to still be engaged in treatment at 30 days compared to a group that had a brief intervention and referral to treatment, or patients who just had an outpatient referral to treatment. Remember, when you're cycling through opioid withdrawal and trying to stay out of withdrawal just to feel normal, patients are using drugs 3 or 4 times a day, and it's very difficult to make an appointment for follow-up care. You probably have not administered buprenorphine yet. There's a lot of barriers to prescribing buprenorphine. Many people talk about not feeling comfortable doing it, not sure how to do it. People get very hung up on the follow-up or the handoff to an existing provider who can continue buprenorphine. Many people feel that they don't have the X-waiver training, so they're not comfortable. Or some people say that it's just one addiction for another. Now, we know that addiction relates to the behaviors associated with using a drug. So when you actually give somebody buprenorphine, all of that behavior can become attenuated so that the patients can go on with their life and be reunited with their children and work and maintain all of their personal and ADLs and other treatment goals. So buprenorphine really is not one addiction for another. So who can order buprenorphine? In the hospital setting, there is an allowance to allow any clinician to order buprenorphine. So this is coded into the federal regulations, which allows for any patient who's in the hospital for a treatment other than their drug, so patients who are there for cellulitis or for abdominal pain or any other reason that they're in the ED, can actually receive buprenorphine or methadone to treat acute withdrawal while waiting for referral for treatment. So this means that we don't have to have an X waiver in the hospital in order to administer buprenorphine to a patient with opioid withdrawal. So let's spend a little bit of time thinking about buprenorphine pharmacology. First of all, methadone, which we're familiar with, is a full opioid agonist, which means on the y-axis there, as you increase the dose of methadone, you increase the opioid effect. And that can increase to a dose where somebody would have significant respiratory depression and overdose on methadone. Narcan or naloxone is a full antagonist. So as you increase the dose, you never get any opioid effects. Buprenorphine should be considered as a drug in between those two. Buprenorphine is a partial opioid agonist with very high affinity for the mu opioid receptor, which means it binds very tightly to the opioid receptor and displaces other opioids that are bound there. Because of that, it has the effect of preventing someone from being able to use heroin or synthetic fentanyl when they're taking buprenorphine. However, that plateau in the graph of buprenorphine is also related to its ceiling effect, which means it never gets to the full agonist potential of methadone, and therefore increasing doses don't increase the risk of respiratory depression. And this is also part of the mechanism that prevents people from having fatal overdoses when they're on buprenorphine, as well as it decreases some of the sedation effects that we see with methadone. Buprenorphine is often prescribed as buprenorphine naloxone with the trade name Suboxone. It can be prescribed as either a sublingual film or as tablets. The naloxone is placed in the buprenorphine formulation so that the product is not crushed or insufflated or solubilized and injected. So naloxone orally is not absorbed, but the naloxone is present in case someone considers injecting the drug or snorting it or insufflating it. So let's talk about a case and how we would actually dose buprenorphine. This is a typical patient you might see in your emergency department who's a 26-year-old male who's seeking detox, or that's what his chief complaint is written by the triage nurse. When you speak with him, you learn that he's had a history of heroin use since age 19. He has had several inpatient rehabs of varying lengths and had some successful period of recovery following those episodes. He's also had Suboxone or buprenorphine naloxone taper in the past and thought it did address some of his opioid withdrawal symptoms. He has an intake appointment tomorrow afternoon, but he's really unable to make it to the appointment without getting some treatment for his opioid withdrawal. Let's assess his withdrawal. On physical exam, he looks very uncomfortable. His vital signs you can see. He is mildly tachycardic. He's got chills, nausea, severe body aches, and shaky. He's very restless. He's yawning several times while you speak with him. His pupils are moderately dilated. He has rhinorrhea and tearing. He's not particularly sweaty, and he has visible goose flesh. So these are all symptoms of moderate to severe opioid withdrawal. But when you want to quantify that, we use something called a COWS score, or a clinical opiate withdrawal scale. You might be familiar with CWA, or the alcohol withdrawal scale used to dose benzodiazepines in patients with alcohol withdrawal. So this is the similar concept. It can be rapidly assessed by a nurse or a clinician, and one can calculate where they fall in terms of severity of their opioid withdrawal. There's also an app that you can do easily on MD Calc that will calculate all of the parameters that go into the score. This should take 1 or 2 minutes. Then we have algorithms that will be distributed with this program that tells you if the COWS score is at least 8 or greater, you can give buprenorphine 4 or 8 milligrams sublingually or orally, depending on what formulation your hospital may have. The patient should have some increased or decreased in withdrawal symptoms or feeling better, and you reassess them after 30 to 60 minutes. And then you can give subsequent dosing depending on how long the patient will have to wait until they have their follow-up appointment. We usually target 16 milligrams at the end of a couple-hour stay in the emergency department. In this case, the patient gets 4 milligrams of buprenorphine and feels a lot better, but he still feels like he has some withdrawal symptoms. You give him another 4 milligrams after about half an hour to an hour, and he's feeling much better. You can talk with your social worker at that time. In this case, he already has next day follow-up for a warm handoff, but a warm handoff is an important bridge to a provider who would be expecting the patient. Many emergency departments are building ED buprenorphine programs at the same time that they're improving and increasing their ancillary resources for referral. And that's very important so that the patient feels welcome when they show up at their follow-up appointment. And then don't forget to discharge a patient with a prescription for naloxone. This life-saving medication has been so critical in mitigating the opioid crisis, but requires a couple minutes of explanation, and ideally a caregiver or another person would be with them to be familiar with how to dose the naloxone in the event of an opioid overdose. Sometimes people talk about precipitated withdrawal. Precipitated withdrawal is the worsening of withdrawal symptoms when somebody has their first dose of buprenorphine. This can sometimes occur if their COWS score is less than 8, or if they have been using other substances and have not necessarily waited 8 to 12 hours from their last dose of an opioid. Precipitated withdrawal is often treated with increasing doses of buprenorphine. As you use the lower dose of buprenorphine, that might precipitate withdrawal, but as you get up towards 8 and 12 and 16 milligrams, that mitigates the precipitated withdrawal. So that strategy can be used if a patient feels worse instead of better after their first dose of buprenorphine. Again, warm handoff programs, sometimes we call this a warm bridge because we don't really want to hand the patient off. We want them to know that they can come back to the emergency department if they need to. But programs that have established a warm handoff have found much higher rates of continuing in care following an emergency department visit. So in summary, buprenorphine is an evidence-based treatment that any clinician can order in the emergency department to treat opioid withdrawal and bridge to follow-up. A COWS tool or COWS scoring system is helpful to gauge withdrawal severity. COWS greater than 8 equals a dose of buprenorphine. Don't forget to prescribe naloxone and try to seal a warm handoff or warm bridge to follow up for any patient who is treated in the emergency department. Thank you. And these are the references for some of the articles that we discussed in this webinar.